I'm not sure that this talk really fits in this session, and I think I'm pitch hitting for someone who pulled out at the last minute, but nevertheless, let's go. So these are some disclosures. So this slide depicts in the pressure volume domain, I think, the primary hemodynamic effects of ECMO. ECMO increases afterload, and since the ventricle has to eject the blood through the aortic valve, blood will be retained in the ventricle until by Starling's mechanism it can overcome this new increase in blood pressure. And this is why wedge pressure and end diastolic pressure increase. This is a very recent review article from a bunch, several experts, some of who are here. And you see the depiction of what's happening in the CVP. As the flow goes up, CVP goes down, but left atrial pressure goes up, wedge pressure goes up, pulmonary pressure goes up, and left ventricular pressure goes up. And in red, you can see that the aortic pulse pressure goes down, indicating progressively less aortic valve opening. So this is really theoretical in nature. But here is an actual, there's not a huge amount of actual hemodynamic data about ECMO in any setting, but this is an animal study. And if you read it from the right to the left, you can see from baseline, as the flow is increased, the LV, EDV, and diastolic volume goes up. The CVP goes down, but the aortic pressure, as it goes up, the pulse pressure is coming down. So this theory actually is recapitulated in at least one preclinical model. And as you all know very well, this is one of the consequences here, where you have no aortic valve opening, and that then goes along with pulmonary congestion, stasis in the atria of the ventricle, thrombus formation in the ventricle with the stasis, and this can be extreme with aortic valve thrombosis, and also maybe some of you have seen complete ventricular thrombosis. So these are obviously very detrimental. So how to unload or vent the ventricle into these conditions? There are at least 10 different ways to go about this. This was from a review article that we wrote now already 6 years ago. And since then, there are 2 additional things that have kind of come up. So you can reduce the speed of the ECMO. You can add inotropes to get the aortic valve opening. You can use aortic balloon pump to reduce afterload. You can have atrial septostomy to vent blood from the left atrium and the lungs into the right atrium. You can use active sucking using the tandem heart. You can use a surgical left ventricular event, and you can use Impella. And then more recently, PA catheter drainage, and also this concept of LAVA, where you have a cannula across the septum that's simultaneously draining blood from the right atrium and the left atrium and the right atrium. And these approaches were also discussed in this recent review article as well. They discussed 6 of them, but in addition, we can kind of reiterate these other approaches that can be used. Now, of all of these approaches, really, the Impella and balloon pump are really the most common approaches, at least mechanical approaches, to achieve venting. And the question is, do these provide any benefit, and is one better than the other? So this is from a meta-analysis from 2019, led by some colleagues at Columbia University. At the top here, you see all of the, At the top here, these are all balloon pump studies. These are Impella studies that were available at the time. And bottom here is more surgical and tandem heart. And what you can see as the result of the meta-analysis is that on the balance, the mortality favors patients who are unloaded. And there's a signal for both balloon pump and for Impella. More recently, this is another study from Germany that I'm sure many of you are aware of. This is from a registry, multi-center cohort study that compared patients with venting and without venting. And it's a relatively small number. It's about 500 patients. But it does show that there's a favorable effect of combining ECMO with Impella. This is after some propensity matching from the cohort, so trying to account for baseline imbalances. And you've seen this slide before this morning from the same group. They're showing that survival is better if the Impella is placed either at the time or before the ECMO as compared to if the unloading is done after. So this is kind of addressing the question of when would it be more optimal to unload. And now here, this is another meta-analysis that compares venting with Impella and venting with a balloon pump. And as you can see here, there's really not a huge difference. There's some scatter between the different studies. However, on balance, there's really, at this point, there's kind of equipoise between balloon pump and Impella. So next the question is, in these retrospective registries and cohort studies, we don't really know why patients got unloaded. Was it for cause? Was it prophylactic? Et cetera. So who to unload is another major question. And as we've already seen, in theory, ECMO loads the heart, in theory. But as you all know, the response to any device therapy varies significantly among patients due to baseline characteristics and secondary device effects. In fact, this is results from a recent study from Dr. Yiannopoulos in Minneapolis, where he's showing that compared to low-flow ECMO, when you increase the flow, contrary to theory, that in his patients, actually the heart gets more unloaded, which is really the opposite of what theory would tell you. Theory tells you that when you increase the flow, the loading increases. So we don't know what is the deal here. This is an interesting cohort. This is a cohort that has survived ECMO and is undergoing a weaning protocol. And I think I see other people in the audience here who also believe that ECMO does not load the ventricle in a majority of cases. So we don't really know, and there's certainly a lot of controversy. Nevertheless, we go back to this recent review article, and you can see these are kind of indications for when you would consider unloading. But I think the most relevant of these is really the hemodynamics, which is, we can argue on the numbers, but increased wedge pressure and decreasing pulse pressure, these are indicating volume overload in the ventricle and the lungs, and progressively decreasing aortic valve opening. These other things that you can look for, are a little bit later in the game, and if they're present, could potentially be leading to some of the less benefits of unloading that you would see later in the game. So I think that looking at the wedge pressure and the pulse pressure when available, these and maybe an echo looking at aortic valve opening are things that are much more early in the course that can help you make the decision. So in practice, how many patients are getting unloaded? And this is from the ELSO registry. You can see 12,700 patients, of which only about 30% of patients are getting unloaded, and this is across a decade from 2010 through 2019. And you can see that has not really changed very much. It was initially all with balloon pump, and more recently, since 2017, there's been an uptick and a decrease in balloon pump and an increased utilization of Impella. So where are we now? Really, the only study that I'm aware of right now that is in progress is the Unload ECMO study. This study is a prospective randomized study in patients with severe shock with lactates greater than 5, and it's comparing ECMO versus ECMO plus Impella up front, with the primary endpoint at 30 days and intending to enroll 198 patients. So I think there's no clinical parameters right now that you can use to predict which patient is going to require, is going to have a significant amount of loading or aortic valve closure. There are many things that you can look at for clinical signs of LV overload. There are multiple means of venting and unloading the LV, and I think each of those 10 aspects have a role, and it's important to know them, and also, more importantly, maybe to understand their limitation when not to use them. Some of them would be relatively contraindicated in some cases. And I guess the issue of prophylactic versus for-cause use of venting is really a big question now. Thank you. Oh, and I'll just make one, when it comes to unloading, one cheap one advertisement is for the ACURE Symposium, which is going to be in London in association with ESC. Is this ACURE meeting is all about understanding unloading in every, in all conditions, in shock and chronic heart failure, et cetera. So cheap shot there.
Excellent.
Thank you.
Thank you very much for the talk, Dr. Berkhoff. To make sure that everyone gets their coffee, we'll do one question. I'll open it up to the panelists first and see if someone would like to.
So I have a question, Dan, for you. You're interchanging venting and unloading. I'm a little bit surprised about that because in the LVAD literature, you know that a lot of patients have an opening of the aortic valve. That doesn't mean that it decreases the left ventricular end diastolic pressure. Neither there is effective cardiac output.
That's
so
right.
if you're really looking for LV recovery, especially when you're putting an ECMO in dire circumstances and you're wanting to recover that ventricle, you really need to unload the ventricle. Just getting the blood just because the aortic valve opens is not. And I've had arguments with my chief multiple times.
No, absolutely.
The aortic valve is opening, so it's venting.
Unloading means that the end diastolic pressure is markedly reduced. I mean, its volume is reduced and wedge pressure is reduced. Venting just means that you're taking blood out of the ventricle. Venting can actually worsen, in some cases, can worsen aortic valve closure. So you really have to be careful and really, look at, just be specific about what you're talking about.
All right, everyone, thank you.